This is kind of where we left off as soft tissue injuries, and they're divided into two categories, open or closed. And your open injuries are going to be what we call penetrating, or they have an opening through the skin, whereas closed injuries, soft tissue injuries, are more like your bruises and your hematomas, and there's no break in the skin. And a wound is classified, so all wounds are classified as open or closed. In closed wounds, the skin remains intact, so the only closed wound could be a bruise with some swelling beneath it. If it has some swelling beneath it, we call that a hematoma. Small blood vessels are broken, it causes that area to swell. So a bruise or hematoma. Open wounds then include a break in the skin. So a scrape or a road rash or rug burn, whatever you want to call it, the medical term for that is an abrasion. And that occurs when the skin is rubbed across something that's rough. You can sometimes have a lot of impaled objects, like a little bit of pebbles, very small rocks or gravel or glass in that abrasion. So those we would want to kind of wipe out as much as we could with a dressing, and then dress and bandage those. So here's a nice, kind of look. It almost looks like a burn injury, but it's that road rash, and it just shows you it's got small capillary bleeds to it. A puncture wound then has something that's very sharp that penetrates the skin itself. Sometimes you have to look at whatever that projectile is, whatever that impaled object or whatever punctured it, how long it is, to determine how deep that injury is. Puncture wounds usually don't bleed a whole lot. If it's impaled, that means that whatever that object is, it's still in the skin. And for the most part, we leave impaled objects in. Think about, you look at your car and you've got a nail in your tire. And right now your tire is good. There's no leak or anything. When you pull that nail out, now you got a flat tire. So when you pull impaled objects out of the skin, it was holding that blood in this certain place, keeping it from flowing. And when you pull that object out, it makes a hole and it begins to bleed. So a gunshot wound and knife wounds are a special type of puncture wounds. Gunshot wound would be high ballistics, and a knife wound would be a low ballistic. So this is somebody who's got a nail through his finger, hopefully not through the bony part. You don't see a whole lot of bleeding, do you? That's because that impaled object is keeping it from bleeding. When you pull that out, then there's going to be some problems. So we're going to dress and bandage that wound, keep it immobilized in that position, and transport him just like that. A laceration is the most common type of open wound, and it's commonly called a jagged cut laceration. Most minor lacerations don't require much care other than have they had their tetanus vaccine within the last 10 years. Is there a chance of infection? You want to make sure that it's washed out very well. But large lacerations a lot of times can cause a lot of bleeding and can become life-threatening. Both of these, depending on how gaping the wound is, may need sutures or staples or tape or glue or something like that. Here's an example of some lacerations. The bleeding's pretty much controlled, and that's because of the body's ability to vasoconstrict, constrict those vessels that normally would bleed, as well as promote platelets, the clotting part of blood. But you can see how it gapes, and you can see the underlying tissue. That person is going to need some sutures in there, as well as wound cleaning really well. That's a nice laceration. Avulsions and amputation. Avulsion is a flap of skin that gets torn away. So if the entire body part, like an arm or a leg or a foot or a finger, is torn away, then we call that a traumatic amputation. Amputated body parts. Number one, we should find them, put them in a bag, label that bag, keep it cool. And how do we keep it cool? If you have an ice chest or something like that, wrap it in the plastic, wrap it in gauze, and then place it not directly on ice, but in that ice-carrying container to keep it nice and cool. Take it to the hospital, hopefully with the victim. But if you have to go back and locate it later and then transport it, make sure it goes to the same hospital for possible reattachment. Here's an example of an ice avulsion. So they had a flap of skin that was actually torn loose, and then wherever that skin is at, it'd be great if you could find it. Then they could graft it back on there for the most part, but otherwise they're probably going to have to graft that skin from someplace else, usually the abdomen or the buttocks, to close that up. So most bruises don't require much treatment at all. You can put a little bit of ice on there, especially if there's a little bit of a hematoma, and maybe some gentle compression, and then keep it elevated. All major contusions, since we don't know if there's an underlying fracture, need to be splinted. We're going to talk about that in our next chapter. If there's bleeding associated with wounds, stop the bleed. Stop the bleed. Airway, breathing, circulation. It is the C part of your ABCs. Circulation. Stop the bleed. Dressing and bandaging. When we look at what types of dressing and bandage we're going to choose, it depends on the wound. So in normal soft tissue, we use dry sterile dressings. We use direct pressure. And in using that dressing and bandage, we're not only going to control bleeding, but we're going to prevent further contamination because you've got a hole there. It's going to start inviting infectious materials in. We want to immobilize that area. The less they move of it, the less it'll bleed. And then if there's impaled objects, we want to prevent movement of that. So a dressing is what you're going to put directly over the wound. Once that dressing's in place, you can apply direct pressure on top of it to stop any bleeding. And the three most common sizes are your 4x4 gauze, your 5x9 heavier pads, and then your 10x30-inch trauma dressings. If that wound continues to bleed, just a little bit, put additional gauze on it. Remember I told you we don't want to pull that gauze off, or it will break those clots that have already formed and it will continue to bleed more. So you put additional dressing over it. If it's bleeding a lot, then we want to go straight to a tourniquet. So this kind of depends on how much it's bleeding. Dressing goes directly over the wound. A bandage holds the dressing in place. And two different types, your triangular bandage and your roller gauze bandages. Those are the two main types. When you bandage a dressing, make sure that the the dressing completely covers the wound, and then the bandage completely covers the dressing. Wrap tight enough to control the bleeding, but not so tight that they say, oh, my leg's feeling numb or my hand's feeling tingly. You're cutting off blood supply, so be careful with that. Check circulation regularly. Cap refill, can you feel me touching you, that they don't get numb there. And then secure that bandage so it can't slip off. Standard precautions, gloves. You're dealing with people's blood. If there's a chance of splatter, then make sure you have facial protection also. It's good to double glove. Again, you can work with the patient, stop the bleed, and then you have contaminated gloves. As you peel them off, you got a fresh pair of gloves underneath. Don't know why this isn't playing. We were doing so well with some of those other ones. Face and scalp wounds. So you have to think about this. The more cushioning that the skin has, the less it's going to bleed. Like for most of us, we got a little bit of cushion, whether it be fat or muscle, on our buttocks. We fall on the butt, and it doesn't grossly bleed. Whereas you touch your forehead right now, and you go like, wow, I don't have a whole lot of cushion or a lot of fat up there on the forehead. And the face is very vascular. There's not much cushion there to absorb energy, so if somebody walks into something and they cut that scalp, it bleeds a lot. For the most part, just simple scalp lacerations can be controlled with direct pressure. But if that bone fragment, if it's something really deep, like they fell off of a building or got hit by something in the head, and that bone fragment moves in, then we want to make sure not to put direct pressure because we're pushing those bone ends into the brain. So it's a nice example of somebody that's got a laceration to his forehead. They use 4x4 gauze dressing with direct pressure. The bone fragments, you didn't feel anything shift inside toward the brain. And once the bleeding is stopped, then they wrap it with a roller bandage to hold it in place. And you can see the bleeding stop because it's white. The dressing is white, the bandage is white, there's nothing bleeding through. You don't see the blood tinged in there. If there's a wound inside the cheek, you may have to hold a gauze pad inside the mouth, not inside their teeth where they can bite you, but just inside the cheek, making sure the airway's open. And again, scalp lacerations that have maybe brain tissue or bony fragments, don't apply pressure on those. Just wrap very loosely. We're going to get into head injuries in Chapter 14. With head injuries, the neck and spine may also be injured. So if you have somebody with a lot of trauma to the head, think about immobilizing that neck and spine as soon as possible and watching for airway and breathing the whole way through. Nosebleeds can result from injury. Somebody got punched in the nose. High blood pressure, dry air, sometimes stress can cause nosebleeds. So a nosebleed with no apparent cause, just called a spontaneous nosebleed, we want to look for that underlying reason that they're having a nosebleed. And the most common thing that people will do is pinch their nostrils and lean their head back. They feel like the blood's coming out of their nose, so if they tilt their head back, no more blood comes out of their nose, and they are correct. But where's it going? Well, as they swallow, it's going down into their stomach. The stomach doesn't like blood, so as it congeals and clumps together, then the body will start to reject it and throw it up. So a better thing is to have them sit down, pinch the nostrils, and tilt the head slightly forward. We're going to hold the nostrils together for at least 5 minutes. And after the bleeding is stopped, I know it feels yucky, they feel like they need to blow their nose, but ask them not to, because obviously that's going to start the bleed again. If the nosebleed consists or persists or it's very severe, make sure we transport. Check the blood pressure. Check for signs of why did they have that nosebleed. If there's an eye injury, like a laceration or a burn or anything, we want to cover that dry sterile gauze pad unless the eye is visible, meaning that the eye lid was lacerated and the eye is visible, then you'll want to moisten that dressing. If it's a foreign object, you can try to flush it out with a saline solution. So those little 500 milliliter containers of sterile water or normal saline is like a tear. If you puncture one hole in the top with a needle and then just squeeze the container, you can use that as a nice little flush to see if you can remove the object from there. Impaled objects will want to be mobilized in place. We don't remove impaled objects, especially from the eye. And because we have this thing called the sympathetic eye movement, if my left eye moves left, my right eye moves left also. I can't make the eyes move independently of each other. Therefore, if I have an injury to one eye, to make sure I don't move the injured eye, I have to bandage both eyes. Really have to communicate with the patient a lot. Try to keep their ears open, their nose open. Let them know what's going on, because they're blind when that happens. Neck wounds, any holes in the body from the chin to the lowest rib, anteriorly in the front, posteriorly in the back, or laterally on the sides, needs to be addressed and covered with what we call a non-porous or occlusive dressing. So you can see this person has a neck wound, something that lacerated it. Looks like dark red blood flowing from a vein, maybe the jugular vein, and those veins are actually large enough to draw air embolus into there. So we want to cover it with a non-porous dressing. Some cases may be very rare. You have to put a finger above and a finger below the injury site to prevent further neck bleeding. That also stops the blood flow in that neck. So you think about to the head or whatever. So that's a rare instance. If there's trauma to the neck associated with possible spinal injury, then you have to make sure to maintain the patient's airway and stabilize the neck in a neutral and inline position. Injuries to the chest and the back. Remember, from the chin to the lowest rib, if there's a chest injury, we really think about it puncturing that lung, and air can start escaping that lung, and that lung will begin to collapse. They may cough, and if they do, it'll be bright red blood, sometimes very frothy. Remember the strawberry milk analogy? We want to cover that open chest wound with an airtight seal, that occlusive, non-porous dressing. Give them high concentrations of oxygen. Seal the wound. The very first thing, so if you have somebody that has a gunshot wound to the chest, you can take your gloved hand and put it over the hole. You have made an occlusive dressing over that hole. If the breathing becomes more labored after you seal that wound, then you want to remove the seal briefly to let air escape and then go ahead and reseal the wound. And notify ALS, notify the ambulance transport team of what's going on. Impaled objects. Use a stabilizing kind of dressing, something that keeps it in place, something that keeps it from being shifted, because every time it moves, it cuts into that patient's body. So here's an example of like an ice pick, a nice impaled object into the abdomen. So they've removed all the clothing around there, they made a bulky dressing, they've stabilized it in place. A good thing with abdominal wounds like this, if you'll flex the legs, bend the knees upward, that takes a lot of the pressure off that abdomen, and that really helps a lot. Closed abdominal wounds, like from a blunt trauma, blunt object, you're going to see some bruises, and they may be bleeding internally, so we look for signs of shock. Again, if you put these patients on their backs, make sure you flex the knees. Conserve body heat, cover them because they're going to show signs of shock. If they start vomiting blood, it may be an indication that they're bleeding either from the esophagus or from the stomach, and arrange for prompt transport. That's the biggest thing. They need to go to surgery and see where that bleeding's coming from. If they're open abdominal wounds, from like a slashing of a knife or other sharp object, the intestines are in the abdomen under pressure. If there's any kind of opening into that layer, the intestines will protrude. They'll start sticking out. So here's one rule of thumb to think about. So far we've talked about dry, sterile dressings for most open wounds. We talked about occlusive dressings for anything affecting the neck or the chest. And now we're going to say on this one you want to moisten the dressings. Why? Well, the intestines, hopefully the surgeon will be able to put the intestines back in, and if the intestines are left outside the body to dry, then they're going to start dying. So by keeping the intestines moist and sterile, then the surgeon can replace them. We don't replace them, but the surgeon can. So it shows, just a little protruding bowel. He's bleeding from that. You put moist, sterile dressing down first, and then an occlusive dressing over it. This is a classic picture from all books, and they take tape and go around the edges to seal it in. Well, guess what? Your patient's bleeding, and tape doesn't stick to blood. Your patient's sweaty because they're in the first stage of compensated shock, and the skin is going to sweat. Tape doesn't stick to that. So what I'm trying to tell you is, good luck with that. I think the best thing they're saying now is once you put the sterile dressing on there, if you have saran wrap not real tight, because more pressure you put, the more chances that loop of bowel can continue to come out, but wrap the abdomen all the way around with like saran wrap. Flex the knees. If you bend the knees up, it takes pressure off the abdomen. A little bit here on genital wounds, male and female genitals have a rich blood supply. So injury to these parts can cause a lot of bleeding. So as silly as it sounds, direct pressure, dry, sterile dressing to any open wound, and it may be embarrassing to the patient. A lot of times they'll be able to control the bleeding themselves, and they would rather do that, but it just kind of depends. Wounds to the extremities, the dry, sterile dressing is good. We like to stay away from elastic bandages, just tight enough to hold it in place, but not so tight that we restrict and constrict blood flow to that area. If we see that it's got a lot of bleeding or swelling, you may want to think about elevating the injured part as long as there's no evidence of like a skeletal fracture or a bone injury. And then if we splint those, it'll help control the bleeding, whether it's actually fractured or not. So it shows direct pressure, and then once the bleeding is controlled, wrapping it with either a triangular bandage to hold it in place or a gauze roller bandage to hold it in place. Gunshot wounds, most gunshot wounds mortalities result from internal blood loss. So gunshot wounds to the head, the trunk, and the neck, those are going to be, major cause of brain and spinal cord injuries that are, have a pretty high mortality rate. So always open the airway, Make sure that the person is ventilating and has good circulation. Control any external bleeding. Think about this. If somebody gets shot with a low caliber, like a 22-25, they may have an entrance wound and no exit wound, but it may ricochet around inside. If it's high caliber, they may have an entrance wound with an exit wound. So we always want to look for entrance and exit wounds. Look for signs of shock: cool, clammy skin, rapid, weak pulse. Altered mental status usually shows itself in the form of restlessness, so make sure we arrange for prompt transport for these. If CPR, if their heart stops, then you'll have to start CPR. All bites, whether they be human or rabid animals or ticks or whatever, can cause a risk of infection. So minor bites can be washed with soap and water. We still have to report them, whether they be dogs or strays or whatever. But if it's a major bite, then we have to look at bleeding control and dressing and bandaging. Burns. The skin serves as a barrier for burns. I think this is a good place to stop here because I want to take our time with burns, and we'll do a part 3 on this lesson. Bleeding and shock and soft tissue injuries. I'll come back and cover burns in the next section.